Hi, I'm Amy Bird, the Schools of Excellence and Prevention Coordinator with the Montgomery County Educational Services Center and the Montgomery County Alcohol, Drug Addiction, and Mental Health Services Board. I hold a master's degree in education with an emphasis in curriculum and instruction. I was a classroom teacher for 10 years, a curriculum director for 3 years, and now I am blessed to be working in both the education and prevention fields.
And I'm Allison Scherer, president of Wingspan Training, a consulting and training firm in the field of substance use prevention. I'm an Ohio certified prevention consultant and have worked in the field of prevention for 35 years, including work in youth-led prevention, community-based prevention, environmental prevention, and drug-free workplace. I've also developed and presented workshops, trainings, and other educational opportunities for a wide variety of audiences.
Today, we're here to talk to you about prevention services in schools and why prevention is important to implement in the school setting. This training is brought to you with funding from the Ohio Department of Education and our design partners who have helped us to develop this training: the Brown County Educational Service Center, the Butler County Family Children First Council, Miami University for School-Based Mental Health Programs, the Montgomery County Alcohol, Drug Addiction, and Mental Health Services Board, and of course, Wingspan Training. Today we're going to talk a little bit about prevention in schools, the role prevention plays in protecting the mental wellness of the students we serve, the staff in our buildings, and the families that we serve.
We're also going to learn about some strategies to implement prevention in our schools, and we'll discuss ways to turn some of the practices that we're already using in prevention into best practices.
Before we jump in, let's provide a bit of context here. We know that education and health are inextricably linked. Those of you who are watching this probably understand that and witness the links between health and education in the students and families that you serve.
We know that the more educated people are, the more opportunities they have to access quality employment and in turn build healthy communities. Also, a person's health literacy increases with more education. The more educated a person is, the more they are informed and equipped with strategies to take care of themselves. These healthier behaviors lead to longer and happier lives.
Inversely, a person's health affects education outcomes. There is a link between how healthy we are and how ready we are to learn when we come to school. When a child has unmet physical or mental health needs, that child will have a more difficult time learning. Consider your own needs when learning a new task. Are you able to learn at your best if you are tired, hungry, if you've eaten a poor diet? Maybe you've had a stressful week. If any of these conditions exist, do you come to the table ready to learn? You may be able to process some information, but you'll certainly not be able to perform at full capacity. This is even more true for children because their brains and bodies are continuing to develop.
So health impacts our ability to learn, and the level of education we attain can impact our health outcomes. Wouldn't it be nice if we could just wave a magic wand and make everyone healthy and better able to learn? Unfortunately, we know that health and education do not exist in a vacuum. There are many contextual factors that are at play when it comes to a person's health and educational outcomes. A person's family dynamics, the health of the community where that person lives, works, and plays, the social policies that govern that person's access to health care, jobs, and even education, and even our societal norms that craft our perceptions of mental and physical health. These will all impact a person's health as well as their education outcomes.
When considering the inseparable variables of education and health, it becomes clear that schools are an important player in the health and education game. Schools exist in the contextual factors section of this diagram, and the role of our schools in affecting these outcomes for individuals cannot be ignored. So let's discuss what a school can do to positively impact not only education outcomes, but a person's health outcomes as well.
But for the purposes of our discussion today, we're going to focus on how a school can affect the mental, emotional, and behavioral health outcomes of the students and families we serve. For the sake of establishing a common language, let's first better understand the terms mental health, emotional health, and behavioral health. Mental health is how well our minds process and understand information and experiences. Some mental health disorders are biologically based and caused by brain chemistry or genetic inheritance, like bipolar disorder, schizophrenia, depression, and anxiety. But our mental health is also made up of our emotional and behavioral health. Emotional health is about the emotions that arise from what we have learned and experienced. Emotional health is having an awareness of our emotions, as well as actively understanding, managing, and appropriately expressing them. Behavioral health, on the other hand, is about how we behave as a result of those experiences. We can impact our overall physical and mental well-being. Behaviors like drinking or using drugs can impact the brain's chemistry and cause or worsen mood disorders such as depression or anxiety. And on the flip side, some people may actually use alcohol or drugs to self-medicate pre-existing depression or anxiety. Of course, behaviors like eating well, exercising, and taking care of our physical body are just as important for mental health. Strategies that keep us physically healthy also keep us mentally healthy, and vice versa. All aspects of our health are interlinked. In fact, emotional and behavioral health are usually seen as a subset of our overall mental health. However, when preventing and treating problems, it's helpful to name each component as part of an interlinked spectrum. This is why we use the term mental, emotional, and behavioral health, or MEB for short.
In schools, we might use the term social-emotional learning, trauma-informed care, mental health therapy, or other words to describe the services that we provide to support the mental, emotional, and behavioral health, or MEB needs of students. We'll dig more into these terms later. So let's take a minute to look at where we are with regard to the MEB health of our students, both nationally and in the state of Ohio. Let's start with some behavioral health statistics. These statistics come from the National Youth Risk Behavior Survey. Luckily, thanks to great prevention efforts, overall youth alcohol use has been on a downward trend in recent years. And Ohio statistics, particularly among high school students, have been lower than national averages. Ohio should continue to focus on students during the transition years from middle school to high school and from high school to college. Those age groups of students have higher rates of experimental use of alcohol as well as regularly drinking, with 40% of 8th graders reporting taking more than a few sips of alcohol on a regular basis, and high school seniors reporting higher rates of drinking than other high school grades. Another victory for prevention has been around youth tobacco use. Students' perception of harm when it comes to using cigarettes and their actual use of cigarettes has dropped significantly. In recent years, the national trends of cigarette use among high school students have dropped from roughly 11% to 6%. And in Ohio, there has been a cliff dive from 15% to roughly 5% of students reporting that they smoke cigarettes. Prevention strategies work. Unfortunately, we know that tobacco companies, with the release of vaping and electronic cigarettes, have attracted a young audience. National 2019 data showed that half of high schoolers tried vape products, and 30% reported currently using them. Data from Ohio is fairly similar to national statistics. Needless to say, there's some work to do around this new form of tobacco use. National statistics show that high school youth marijuana use has remained steady over the last few years. However, the data show that the chances that youth use marijuana increases through high school. In 2019, data showed that 14.6% of 9th graders reported using marijuana, but 28.3% of high school seniors reported using marijuana. Another concern is that 10.2% of middle school students in Ohio reported using marijuana. These are statistics that we will want to watch as the legalization of marijuana makes its way to the ballot in many states. National student opioid use has remained steady over the last few years at roughly 14% of high school students reporting that they use prescription opioids without a doctor's permission. Ohio's data runs slightly lower than the national average at 12% of students reporting misusing prescription opioids. Our work in prevention certainly needs to be targeted towards student drug and alcohol use, but both national and Ohio data show that student mental health prevention efforts are in need of serious attention. High school students have reported feelings of sadness and hopelessness at increasingly alarming rates, with a 7% increase from 30 to nearly 37% over the last 6 years. There has also been a 1% increase in high school students reporting thoughts of suicide over the last several years. Ohio's numbers have also shown a 7% increase over the last several years, from roughly 26% of high school students reporting feelings of sadness or hopelessness to 33%. And as recent as 2019, suicide has been reported as the leading cause of death in ages 10 to 34. Some of these stats do not look so promising, but there is hope. As we've said before, schools play a key role in helping change the MEB health outcomes for kids. Schools have an opportunity to help create positive, supportive environments where students can learn, be healthy, and feel safe. And of course, there's the concept of that one caring adult. We know that one caring adult outside of a student's family can change the trajectory of that student's life. So it's important not to underestimate the power a school has to make a difference in the life of a student and for everyone in the community.
We saw that student behavioral and mental health in Ohio needs some serious attention, particularly around students' feelings of sadness, hopelessness, and suicidal ideation. And Ohio's been hit particularly hard by the opioid epidemic. But Ohio's lucky in that we have had administrative leadership who has worked to address the issue. Mike DeWine began the work during his days as Ohio's Attorney General under Governor Kasich. From this work, the Attorney General's office released a resource guide to help schools implement research-based prevention best practices into schools. A link to this resource guide will be provided in the resources that accompany this video.
Upon taking office as governor, Mike DeWine created the Recovery Ohio Initiative. And as a result, in 2019, $18 million of the state budget was set aside to help schools implement evidence-based prevention programming. And another $1 million was given to the Ohio Department of Education to distribute to educational service centers to provide professional development to teachers, administrators, and other school personnel on the model and tenets of prevention.
In his own words, the governor has stated that Ohio is in the midst of a public health crisis. Based on reports from the Ohio Department of Health, about 13 Ohioans die each day from unintentional drug overdoses. Approximately 5 people a day take their own lives. The repercussions of the drug epidemic and mental illness have touched the lives of all Ohioans, regardless of their race, ethnicity, or socioeconomic background, and every community in our state has been affected. The governor has also stated that we must reduce the stigma and provide impactful prevention education for Ohio's children beginning at an early age.
Recovery Ohio also seeks to provide mental health and wellness services for adults who need treatment or recovery services. But this initiative has taken great strides in ensuring that Ohio's children have longer, healthier lives free of MEB health issues. Let's take a moment to pause and reflect. It is likely that there are prevention resources you've seen in your community to address the MEB health of the people you serve. Pause the video and take a moment to make a list of the prevention resources available in your community. Unpause the video when you're finished and hang on to the list you've made. You'll need it for an activity later in the presentation. We hope you took a moment to make a list of the prevention services you see in your community. Don't forget to hang on to the list for an activity later in the presentation.
So let's talk more about what prevention is and break things down a bit. This figure, most recently updated in 2019, comes from the National Academies of Sciences Committee on Fostering Healthy Mental, Emotional, and Behavioral Development Among Children and Youth. This diagram is based on the model developed by the Institute of Medicine and has evolved over the years as the research in the MEB health field has expanded. And we have learned more about what works and what doesn't work. This half-pie diagram represents the continuum of care for ensuring MEB health. When people hear the term mental health services, it's easy to think about treatment services, like going to see a mental health counselor. But the continuum is more than just the treatment services people need to get well. It also includes the maintenance services to help them stay well. We also want to prevent problems and promote MEB wellness at all levels of our community. Let's take a deeper look at both promotion and prevention. You'll notice that promotion is not only a section of the pie with 3 wedges, or pieces of pie, but it's also the arrow at the bottom that spans the entire continuum of services. Regardless of where any one person is on the continuum of care, we want to promote health and wellness. Here's a great way to relate to the promotion arrow that spans the continuum of care. Think about the last time you went to the dentist office for a checkup. Did you get that little bag of toothpaste, a toothbrush, and some floss? Of course you did. And if you staked out the dentist's office and watched everyone leaving after their 6-month checkup, all of them would have gotten that little bag, regardless of where they fell on the dental continuum of care. Have frequent cavities? You get a bag. Have periodontal disease? You get a bag. Even those folks who get a gold star and are 100% seal of approval on their mouth health, the dentist doesn't say, "Susie, your teeth are in excellent health. You never need to brush or floss again." No, Susie will still get a bag.
Our medical doctors do the same thing. As we are leaving the doctor's office after our annual checkup, do they say, "Oh, don't worry about it. You're fine. No need to exercise"? No, they tell you to eat well, exercise, and stay healthy. And it doesn't matter what diagnosis I walk into the doctor's office with. Diabetes, eat well and exercise. Heart disease, eat well and exercise. Completely healthy, keep up the good work and eat well and exercise. The same is true with mental health. There are things that we need to do to keep ourselves mentally well, sort of a checkup from the neck up.
The promotion arrow also reminds us, again, that MEB health and physical health are completely linked. They cannot be separated from one another.
A few examples of promotion strategies that we can use in the classroom might be to give kids a chance to get up and move. This keeps their bodies healthy and gives their brains a rest so they can come back ready to learn. Recess is another example of a promotion strategy, and so is taking a moment for all students to do some mindful breathing. Deep breathing calms the nervous system and makes it easier to concentrate and focus. You may be using some of these strategies already to optimize learning, but what you may not have realized is that these exercises promote lifelong MEB health.
Turning to the promotion section of the pie, we see it contains 3 wedges: individual and family, community, and societal. Our MEB health does not exist in a vacuum. Research has linked an individual's well-being to the well-being of their community, including schools and healthcare services, and to the well-being of society as a whole. Research also shows that genetics and biology, as well as social and environmental influences, all play a role in individual MEB development. For example, societal factors like a group's social norms around drug and alcohol use can encourage any member of that group to make high-risk drug or alcohol choices. The environmental, economic, and social health of the community where a person lives, works, and plays also affects their MEB health. And of course, an individual's experience of their family's dynamics can also impact MEB health outcomes.
To be comprehensive, the continuum of care must look beyond the individual and consider key factors in that individual's environment. Even a change in a state or local law could help to create an environment that supports healthier MEB choices. For example, Ohio is now a tobacco 21 state. This law raised the age of purchasing tobacco and vaping products from 18 to 21. This age restriction makes it harder for youth to get a hold of these products, which decreases the problems they create.
Let's take a look at the prevention section of the continuum of care, which focuses on impacting individual attitudes, knowledge, and behaviors to prevent the development of problems. In this section, we see 3 wedges: universal, selective, and indicated.
Universal prevention strategies are focused on everyone before there is an indication of a problem and regardless of their risk level. So a universal prevention program could be designed for and delivered to groups such as all the 7th graders in a school or district, all the parents at a PTO meeting, or all the athletes in our school buildings.
Universal prevention strategies are slightly different from promotion strategies in that they are delivered to an entire population and targeted toward a specific MEB health issue. For example, we saw earlier that many high school-aged youth have experimented with vaping. So to prevent high school students from trying vaping products, we can provide vaping prevention to all high school students. All high school students will receive the education, thus making the strategy universal. But the messaging moves beyond general wellness strategies and into addressing the specific issue of vaping.
An example of a universal prevention strategy for schools is the Catch My Breath vaping curriculum that anyone can use. The curriculum is available online for 5th through 12th graders and can be implemented with all students in these grade levels. We can use this universal prevention curriculum to target vaping use in our students and reduce the overall rates of youth vape use.
Moving along the continuum, selective prevention strategies are delivered to a group of individuals who are not yet experiencing signs and symptoms of an MEB disorder, but are at greater risk of developing an issue. For example, youth who are related to a person suffering from an MEB issue are biologically at an increased risk for developing an MEB disorder themselves. These youth may have never used drugs or alcohol at this point in their own lives, but they are at increased risk and need strategies designed to prevent the development of their own disorder. These services are very often provided in small group situations with an evidence-based curriculum which educates students about their own risk factors and helps them develop protective factors and skills that have been found to decrease their risk. Children experiencing trauma in families are another selective population, as research has found a clear link between adverse childhood experiences, or ACEs, and the development of MEB problems. Using school-wide trauma-informed practices can be a universal strategy, especially since we may not know when or if a student has been impacted by trauma. But when we do know that a student has been impacted by trauma, these youth will need extra layers of protection provided by selective prevention services to know what their risks are and develop key coping skills, all of which will help to reduce their individual risks for future MEB problems.
In a school setting, selective services might be delivered in a small group. A member of the school staff or a community prevention service provider can use evidence-based curricula designed for a group of individuals who need selective services. For example, the Prime for Life Drug and Alcohol Prevention Program provides a selective level that educates students about their potential risk associated with using drugs and alcohol, encourages students to identify the protective factors in their lives that can help them build resilience, and helps students build social skills to deal with high-risk situations.
In the final wedge of the prevention section are indicated prevention strategies. These strategies are designed for individuals who have experienced problem behavior but have not been diagnosed with an MEB disorder. These services are sometimes called early intervention or intensive prevention. The key is indicated services are for those individuals showing early signs of a problem. Another example of indicated services would be a student who's been identified on a universal mental health screening as showing signs of anxiety or depression. That student needs more specific services which could be provided one-on-one or in a small group to help them stay mentally well. Those youth with needs that go beyond the program would then be referred on to another provider further down the continuum of care. Indicated services are not work that school personnel need to take on themselves. Those services are often provided by a community service provider working in collaboration with a school.
In my 10 years as a classroom teacher, I very often saw students who displayed risky behaviors and used drugs and alcohol. And I, like many of my colleagues, thought that those students needed treatment services. But I quickly learned that treatment services may not always be appropriate, especially when signs of what could be an MEB disorder first present themselves.
Picture a student who is 16 years old, just got his driver's license, and is busted for a DUI. He goes to court and the judge sentences him to drug and alcohol treatment without an assessment, even without a screening. Let's say that teen's use has not progressed to the point of addiction, in fact, is nowhere close. He simply made a high-risk choice to drink and then another one to drive.
And when he is forced into that treatment program and is in a group with other teens who have progressed to addiction, he's going to hear stories and experiences that he has nothing in common with. That teen is going to be quite appropriately thinking, I don't belong here. His resistance will be fortified, and we would have lost the opportunity to meet him where he's at and help him explore his choices in order to prevent further progression. This is the value of indicated prevention services.
Moving along the continuum of care, we have the treatment and maintenance sections. These sections include case identification, treatment of disorders, long-term treatment, and aftercare. Case identification is exactly what it sounds like. A licensed mental health or chemical dependency clinician would perform a diagnostic assessment. Because diagnostic criteria are being applied, an assessment is outside the scope of a preventionist. An individual may be assessed as not having a disorder and can then be referred back to indicated prevention services. For those who are assessed and do meet diagnostic criteria for an MEB disorder, they're referred on to treatment of that disorder. Treatment services are customized to an individual's diagnosis and provided by a licensed clinician. In the case of substance use, once an individual with a substance use disorder successfully completes treatment, they then need to maintain their recovery, which is where aftercare helps individuals stay healthy and prevent relapse. The same is true for many mental health disorders. However, if an individual is diagnosed with certain mental health disorders, they may need long-term treatment to maintain a level of mental well-being. That long-term treatment may be lifelong and include medications as well as regular appointments with a psychiatrist.
It's important to note that many people who are receiving treatment may still need prevention for other MEB issues. For example, a student has a diagnosed anxiety disorder will be at a higher risk for developing an alcohol or drug addiction. So it's important to provide the student with the comprehensive continuum of services they need, which in this case would include prevention and treatment.
Let's circle back to the promotion arrow that spans the entire continuum of care. It is entirely appropriate for a person who is receiving treatment services to also receive promotion services. Remember our dentist office example? Let's say I'm a regular patient with lots of cavities because it runs in my family. I'm still going to leave with that bag of toothpaste, toothbrush, and floss. But I'm also probably on an aftercare plan that includes staying away from sugary foods, brushing more often, and using a special mouth rinse. The same is true for mental health. If I have a diagnosis of anxiety or depression, I will still benefit from health promotion that everyone receives, because eating well, exercising, and meditating are good for all of us, and are especially helpful for those of us with anxiety or depression. But I'll still need an aftercare plan that specifically addresses my diagnosis, whether it includes things like installing full-spectrum bulbs in my house or workplace, or practicing and using key coping strategies recommended by my clinician.
The full continuum of care is needed to maintain a healthy population. Each section has its place in the health and well-being of our students, families, and communities. And by bolstering the promotion and prevention services in every sector of our communities, which includes our schools, we can reduce the demand on the treatment side. The bottom line here is that prevention changes lives. By ensuring every school has a continuum of evidence-based prevention services, we can change the lives of our students.
Prevention can also change outcomes for entire communities. Simple policy or environmental changes can help communities lower their incidence of MEB-related health issues, and communities include our schools.
And prevention saves money. It is much less costly to implement prevention programs and prevent diseases from happening than it is to treat them. The Substance Abuse and Mental Health Services Administration reports that effective school-based prevention programs save $18 for every dollar spent, and comprehensive community prevention programs save $147 for every dollar spent.
Let's pause and take a second here to go back to that list that you created of your prevention services in your community. As you look that list over, I want you to think back to the continuum that we just reviewed. Look at each of your prevention services. Are any of them actually treatment services? Are some of them promotion services? For those that do fit in the prevention section of the continuum, which ones are universal, selective, or indicated? Pause the video and take a minute to label each of the services on your list. After you've done that, unpause the video and we'll continue digging into how prevention can be layered with all the work you may already be doing.
Hopefully you took a moment to categorize the list of services that are available in your school or community. To help you check how you did on the categorization activity, we provided some examples of prevention services that are evidence-based and can help a school complete a comprehensive continuum of services. Let's take a look at what category they each fall in. Teaching students to build relationships is a promotion strategy. So is the use of mindfulness as well as deep breathing activities. The PACS Good Behavior Game, an evidence-based framework for teaching students self-regulation, is an example of a universal school-wide prevention strategy. Small groups for students who are impacted by addiction in their homes or who we know have been impacted by trauma are selective prevention strategies. Small group education for students who are caught vaping is an example of an indicated strategy. And of course, having mental health therapists in school buildings is an example of treatment services.
By now, a picture of the MEB continuum of services in your school should be formulating in your mind. Perhaps you have a mental list of strengths and any gaps that may exist when you assess the services in your building. The more comprehensive the services, the better the outcomes for students, staff, families, and our communities.
Up to now, we've given you many statistics and definitions that have hopefully helped bring context to the word prevention. But why is this work important in schools? Isn't it our job as teachers and educators to teach content to students? Of course it is. But you'll see in recent years that there has been a shift in priorities. As we learn more about what makes a well-rounded learning experience for our students, we've begun to understand that there is more to school than just academic content. Take a look at the Ohio Department of Education Strategic Plan. In the middle, you will see the words whole child. You've likely heard that phrase before, but what does it mean? Let's break it down a bit. The vision in the strategic plan talks about how each child in Ohio is challenged to discover and learn, prepared to pursue a fulfilling post-high school path, and empowered to become a resilient lifelong learner who contributes to society. So how do we build students who are challenged, prepared, empowered, and resilient? The answer is here in the 4 learning domains. You'll notice that the academic content is present. We know that teaching academic content is very important. It is the main goal of our schools. Foundational knowledge and skills like literacy are also of the utmost importance. But turn your attention to the bottom two boxes and you'll see that half of a student's learning experience should consist of social-emotional learning and building leadership and reasoning skills. These skills are how we build empowered and resilient learners who are challenged and prepared for the future. And don't the words empowered and resilient speak to all of the prevention services we just described?
So you might be thinking, great, one more thing. I've already got enough on my plate. Or maybe you're thinking, I hear ya, but we just can't make this shift overnight. You're right in thinking that this is not work that can be done overnight. But this work isn't just one more thing. This work can fit right into the systems that you've already built into your schools.
Many of you have seen this shape. On the left, you'll recognize the academic section, and you've likely had experience building a Tier 1 academic curriculum across the content areas, as well as targeted and intensive interventions for students at a Tier 2 and Tier 3 level. You've probably experienced the same tiered system concept in building supports for external student behaviors. In the tiers of PBIS, we created Tier 1 school-wide positive behavior expectations. And just like with academic interventions, you've probably implemented behavioral interventions at a Tier 2 and Tier 3 level. But think for a moment about all that we have learned about the MEB health of students. Academic outcomes are dependent on a student's health, and a student's health is not isolated from external behaviors. And as we've discussed, our external behaviors are a subset of our overall mental well-being. Science tells us that these two sections of our tiered supports are entirely dependent on this wellness section. So doesn't it make sense that we build supports for students that address the needs of the whole child, not just isolated pieces of academics and behavior? All three sections of this triangle are interlinked. The good news is that we do not have to completely reinvent the wheel when it comes to building a wellness system. By layering together what we know about building tiers of support for students and what we're learning about prevention services, we can provide a cost-effective continuum of MEB services that exist in our schools' tiered systems of support. Building systems of wellness does not have to be one more thing.
Well, that's a lot of information. Let's take a minute to pause and reflect. Think about that list of MEB services that you created earlier. You labeled these services as either universal, selective, indicated, promotion, or treatment. Let's review this list. First, ask yourself if you can expand the list of services. Has anything in this presentation, particularly around the idea of wellness supports for students, prompted you to think of additional services that are already offered to the students you serve that maybe you didn't think of before? Second, let's look at the list from the tiered system lens. Label the services you've listed as a Tier 1, 2, or 3 service. Third, consider any strengths and gaps you see in the services you have listed. When we come back, we'll discuss how we can use our tiered systems to build wellness support services for students. Hopefully, you took a moment to expand on the list of services provided for the students you serve. Also, we hope that you were able to label the services you listed as being a Tier 1, 2, or 3 service. And most importantly, we hope you have an idea of the strengths and any needs of services at each tier.
You should now have a rough assessment of the MEB continuum of care supports that you have in your school's tiered system. The prevention services you labeled as universal should roughly align with Tier 1 services available to students. Selective services correspond with Tier 2, and indicated with Tier 3. As students' risk factors increase, our interventions increase in intensity. The key here is to ensure that there are layers of services in place to meet all students' academic, behavioral, and wellness needs. So let's take a deeper look at what might be included in a school's continuum of MEB wellness supports. Prevention, social-emotional learning, mental health supports, and trauma-informed care are all domains of MEB supports that we might consider when we think of overall student mental wellness. But like we said before, we cannot build these MEB supports overnight. And the terms that we use, such as social-emotional learning, trauma-informed care, mental health supports, and prevention, might be confusing. Where should we turn our attention first? If we focus on one, are we neglecting another? The important thing to remember is that all of these terms overlap. Some come from the behavioral health field and have crossed over into the education field, and vice versa. No matter the origin of these words, all are domains that lead to the same end. Building trauma-informed or SEL classrooms and environments are prevention strategies that can prevent a student from developing an MEB health issue later in life. And we just learned that prevention services are a large part of a continuum of mental health supports.
When defining anything, it's just as important to talk about what it is not. So let's take a minute and look at some of the prevention practices that have been common out there but are not evidence-based or do not meet MEB outcomes. By the way, you may have experienced some of these when you were growing up, and some are still in use today. The examples that we will be looking at may intuitively make sense and are grounded in the best of intentions. And because they seem to make sense and are well-intended, they keep being used. But the fact is, as the science and research has caught up to our prevention practices over the years, we have learned that unfortunately, many well-intended strategies simply don't work. And worse, can even backfire and increase problems. Let's look first at a very common strategy of educating students on the signs and symptoms of an MEB disorder. Teaching folks the signs and symptoms of a disease helps to identify cases and pave the way to treatment, which is a fine goal, but it does not result in prevention outcomes. It's like saying, don't cough, you won't get a cold, or don't have chest pain so that you don't develop heart disease. It seems pretty clear when we look at it through physical health disorders, yet there is far too much time and money spent teaching signs and symptoms of MEB problems without providing any strategies to prevent those problems. And educating youth on the signs and symptoms for something like substance use has been found to backfire. Let's imagine you are an 8th grade girl with concerns about body image. In health class, you learn not only that stimulant drugs can cause weight loss, but also the names of those drugs. Contrary to our best intentions, we have given this student what she sees as the answer to all her problems.
Showing drug displays is another common yet ineffective practice. This well-intended strategy can be helpful for teachers and parents to help them know what is trending, what to look for, and how to talk to kids about it. But when that information is presented to youth in the name of prevention, it simply doesn't work. In fact, like teaching about signs and symptoms of MEB disorders, using drug displays with students can also backfire. Research shows that students who have a tendency to engage in high-risk behaviors would now have new ideas about what to use, what it's called, what it looks like, and maybe even where to find it. We are honing their knowledge and skills for use versus preventing it.
And many prevention messages layer in fear to try to scare people away from certain behaviors by focusing on the worst harms that could result from that behavior. These scare tactics are used by well-intended adults who are trying to protect young people from a frightening danger. By emphasizing the worst possible scenarios to create fear, they hope that the fear alone will prevent risky behaviors. Some common examples of scare tactics include presenting graphic images, mock crashes at prom time, and bringing in speakers in recovery to share scary stories of their use, or family members to share their story about how they lost their child to suicide. These stories may be moving for staff members and students, but the effectiveness of a message cannot be measured in the emotional response to it. Just because students may be shocked or even cry as a result of hearing a person's story does not mean that the feelings in that moment of the message will carry to the moment of choice. Adults hearing that scary message will filter it using logic and rational thinking as well as their life experiences, which tells them that these things can and do happen. In the moment of the message, youth may very well feel fear and other strong emotions, but the adolescent brain is different. It's still developing, especially in the prefrontal cortex with functions such as impulse control, judgment, and decision-making. But after hearing the message, say when the student is at a party or maybe in a situation where they are being offered drugs, they're overcome by the emotions of that moment, like fear of rejection or excitement. The emotions of the moment of choice will be the driving force in their decision, not the feelings they felt at some other time in the school auditorium or assembly room, days or weeks ago.
And let's be honest, youth do not listen to the stories of wisdom from us. How many of you listened to your parents and teachers when you were teenagers? Well, maybe some of you did, at one point or another. But the filter for adolescents is their immortality and how they are different. Let's say I'm 15 and I hear someone who is 35 tell their very powerful story of recovery, and I'm moved by it. I hear that the person stopped drinking when they were 25 and has been sober for the last 10 years. And I think, gosh, that's such a powerful story. I do party with my friends on the weekends sometimes, but I'm 15. I have 10 years before it gets to that point. If I see any signs of a problem, I'll just stop. In my experience as an educator, I have heard of and have seen these stories at all school assemblies, at prom time, or at the kickoff of a drug-free Red Ribbon Week. I certainly remember thinking if my students only knew how dangerous these things were, they wouldn't do them. But I never considered that scare tactics can be traumatizing to an adolescent audience, or that maybe some students in the audience were thinking about continuing high-risk choices like drinking or using drugs until it became a real problem. I care deeply about my students, and my intentions were always to help them, but they needed evidence-based strategies to guide them through the difficulties of adolescence when their emotions were high and impulse and decision-making skills were low.
So now what? What can you do to change MEB outcomes for the students you serve? Luckily, the Substance Abuse and Mental Health Services Administration, the federal MED experts, have a department in their organization called the Center for Substance Abuse Prevention, or CSAP. CSAP has done decades of research and come up with 6 overarching strategies that, when layered together in strategic ways, are shown to actually reduce, delay the onset of, or stop entirely instances of MEB health issues in individuals and communities. I call these strategies the CSAP 6. The first CSAP strategy is education. This strategy involves two-way communication between the educator and student. The education strategy is aimed at affecting knowledge, attitude, and behavior, as well as aims to affect life and social skills like decision-making, critical analysis, and refusal skills. Research shows that on its own, without any of the other CSAP 6 strategies in play, evidence-based education will impact the prevalence of MEB issues in our communities.
Examples of appropriate education strategies vary by age group. In grades K through 6, prevention education should include social-emotional learning skills to build self-management, self-awareness, responsible decision-making, relationship skills, and social awareness. Also appropriate at this age are concepts of what is safe and unsafe when it comes to drugs and alcohol. For example, it's not safe to take things from the medicine cabinet. Education for grades K through 6 should also discuss that most people do not misuse drugs or alcohol. For middle and high school students, they need age-appropriate skills practiced in those same areas of social-emotional learning. They also need to know that most people, particularly their peers, do not misuse drugs and alcohol. In fact, we need to help lift up youth voices through positive peer prevention, which involves drug-free peer educators providing evidence-based prevention messages to their peers about staying mentally well.
The environmental strategy is another one that can stand on its own, meaning that a community who uses an evidence-based environmental strategy, even if no other CSAP 6 strategy is in play, will see improvements in MEB outcomes. Environmental strategies address standards and policies that can impact the prevalence of MEB health problems in a community. Environmental strategies include changing community norms, changing access and availability, media messaging, modifying policies, and the enforcement of those policies. Let's look at a common example. Let's say we have some high-risk drinking connecting football and alcohol in our school and larger community. We can review and revise our athletic code of conduct as needed to ensure it sets clear boundaries for on- and off-season behavior and provides supportive discipline policies, including diversionary education after first violations. We can challenge and work to change the norms among our athletes, coaches, and parents by rolling out our new policy with some normative media messages like, a drug-free team is a winning team, be part of the team. We can work to decrease access to alcohol at home by providing outreach to parents about where and how their alcohol is stored and risks of hosting underage drinking parties after the game or for homecoming.
School personnel can also play a pivotal role in environmental prevention. For example, studies have shown that communities who have higher percentages of alcohol, tobacco, and lottery advertisements on their storefront windows have greater prevalence of MEB disorders. Imagine doing all the work to create a comprehensive prevention approach in your school, only for the students to walk home past the local convenience store daily and be bombarded with advertising and high-risk messaging. But did you know that local communities can pass an ordinance that restricts the percentage of storefront windows that have alcohol, tobacco, and gambling ads? Schools and school personnel can be part of a larger environmental solution by lending their support to advocate for these community-level changes. Before we discuss the other CSAP strategies, it's important to stop here and discuss the interplay between strategies that address the environment and those that address individuals. Comprehensive prevention includes both types of strategies. Think about the example Allison just shared about the connection between alcohol and football in our school community. Now let's suppose there's a group of students, some of them are on the football team, who are caught drinking outside the football stadium after a Friday night game. Unfortunately, the school they attend has a no-tolerance alcohol policy, and the students are suspended for 10 days. Pause the video and answer these discussion questions about the situation. Hopefully you had a chance to pause and reflect on some strategies that might be appropriate in this situation. To answer question 1, the school did not use strategies that would maximize MEB outcomes for these students and future students. Suspension is not a strategy that institutes behavior change on the part of students, and in fact could do more harm than good. These students are engaging in risky behaviors, and sending them home for 10 days could potentially increase the likelihood that they continue to engage in those risky behaviors. So to answer question 2, the students, as we've learned, could definitely benefit from some quality indicated prevention services, including prevention education and perhaps an MEB screening for further MEB problems. Regarding question 3, if the school's policy does not change, future students will be subject to the same consequence. So clearly, an environmental change would need to accompany any individual strategies we provide for the students, further highlighting the importance of the education and environmental CSAP strategies that we've already discussed.
The remaining 4 CSAP strategies cannot stand on their own. Rather, they are best used in support of the education or environmental strategies. Information dissemination is often confused with education, but it's different, in that the educator is simply giving out or presenting information and there's no expectation for dialogue or interaction. Examples of information dissemination include sending home prevention information flyers and posting prevention messaging on social media or on closed-circuit TVs in the cafeteria. It may also include a presentation to parents on the results of your school's recent MEB health survey.
Information dissemination is a great way for schools to stay in touch with parents and get important information out quickly. However, it's important to remember that simply sending home a flyer or posting healthy tips on social media won't reduce the school's incidence of MEB issues. Let's say, for example, that I want to give my students tips for mindful breathing. So I send home a flyer on breathing strategies. Many of those flyers may make it home, but they could be lost in backpacks or on the classroom floor. But if I have been teaching social-emotional learning skills in my classroom, like how to deal with stressful situations with a friend or family member, and I have taught my students how to use mindful breathing as a tool to work through frustration, then my flyer is more than just a flyer. It's now a tool that accompanies and reinforces the lessons I've taught. Information dissemination is a great strategy for raising awareness, but it is best used in conjunction with the education strategy or the environmental strategy.
Community-based process is a strategy that develops the skills of impactors who, in turn, provide awareness, education, and/or skills to target groups. Community-based process enhances the ability of the community to provide more effective prevention services. Some examples of community-based process include professional development for teachers on SEL or behavioral health of students, volunteering for a community coalition or strategic planning group to improve student mental wellness outcomes. This strategy, much like information dissemination, should be done in support of the implementation of education or environmental strategies.
For example, in this training, you will receive information about how to use prevention strategies. You could take this information back to your school team and create a plan with that school team. But this process on its own will not meet the outcome of supporting student mental wellness. Prevention education and environmental strategies must be planned and implemented in order for us to reach our outcomes.
Alternatives are activities that are provided for students that exclude alcohol, tobacco, and other drug use, and provide students an opportunity to engage in pro-social behaviors as a means of reducing risk-taking behavior and/or reinforcing protective factors. Some obvious examples are after-school activities, summer camps, arts and crafts, music lessons, and sports. But community service learning, mentoring, and community volunteering are also alternative activities. All these activities are great opportunities for students to have fun and use their time constructively, but again, when offered alone, without being tied to an overarching prevention education or environmental strategy, will not help achieve MEB outcomes.
For example, hosting an alcohol-free event after homecoming does not ensure that we will reduce the number of students who drink. Our chances of ensuring students make positive choices around alcohol would be much greater if we implemented prevention education to teach students about how alcohol affects their developing brain and refusal skills when in high-risk situations, and then reinforce these skills with a fun alcohol-free event, as opposed to just offering an alcohol-free event. Alternatives are great for promoting positive experiences for students, and we should have opportunities for students just to have fun. But if our intent is to prevent our students from having MEB health issues, then we will need to pair these alternatives with other strategies.
The final CSEP strategy is problem identification and referral. In this strategy, we identify individuals who have engaged in illegal or age-inappropriate use of tobacco and alcohol, or first use of illicit drugs, or those who have shown early signs of other MEB health problems. With these students, we now need to determine if their needs can be met through indicated education, or, if needed, make a referral for a diagnostic assessment by a licensed practitioner. Note that this strategy does not include the diagnostic assessment itself, but rather a determination if one is needed, and then a referral to a licensed practitioner. This strategy, much like alternatives, community-based process, or information dissemination, will not ultimately prevent students from having MEB issues, but it is important in determining right fit services at the right time for individuals.
Also, problem identification and referral does not have to be the work of educators. Preventionists are credentialed through the Ohio Chemical Dependency Board of Professionals to perform this work. School counselors, school therapists, school nurses, or social workers could also perform this work. In implementing problem identification and referral services, the role of the school is to ensure that they have the structure and process to refer any students for screenings and any subsequent services. Does your school have a procedure and resources for making the warm handoff when a student may need additional support? If not, contacting your local mental health board could help you to begin to navigate the implementation of problem identification and referral services.
All 6 of these CSAP strategies can be used in a school's planning process to ensure positive MEB outcomes for students, families, and staff, and will help you build tiers of support for MEB wellness. But like we said earlier, these MEB wellness systems do not build themselves overnight, and you might be wondering, where do I start?
We've actually developed a framework you can incorporate into your school's planning process that will ensure you implement all 6 CSAP strategies into every tier of your school's multi-tiered systems of support. The framework is also designed to address the contextual factors that impact students' MEB outcomes. The work begins with these 8 areas developed by Ohio's Montgomery County Alcohol, Drug Addiction, and Mental Health Services Board in partnership with the Montgomery County Educational Service Center as part of the Schools of Excellence in Prevention program. This program is a planning framework that incorporates everything we have discussed today and allows schools to plan for and implement comprehensive prevention programs across the school community. So how will reviewing these 8 areas ensure that you create comprehensive MEB supports in your school?
If you remember, education was one of the primary CSAP strategies. When we provide quality prevention education to the populations we serve, we can change the MEB outcomes for our entire community. Providing students with quality prevention education at a universal selected and indicated, or Tier 1, 2, and 3 level, will ensure that we equip students with the skills they need to become lifelong resilient learners and individuals who are free from MEB health issues.
Peer-to-peer engagement is another form of student education. It's an evidence-based model that can be used at all grade levels, but is most effective at the middle and high school level. We've listed it as a separate area because students still need comprehensive prevention education from other evidence-based sources, but students can be trained to deliver prevention messaging to their peers. When students are appropriately armed with the information about the 6 CSAP strategies, they can create their own prevention plans that can impact the MEB outcomes of their friends. It's important not to underestimate the ability of our young people to influence their peer group.
We have also listed staff education and parent education as priority areas. To ensure we can provide safe and healthy environments for our students, we have to ensure the adults who care for our students also feel healthy and safe. The staff in our schools should be adequately trained to support students in the classroom with trauma-informed and SEL practices. They should be trained to recognize signs and symptoms of students who may be experiencing an MEB health issue, and trained on their school's referral system if they need to refer a student for their Tier 2 or 3 or selective and indicated supports. School staff should also be trained on when and how to refer a student who is in crisis for the appropriate level of services. And of course, we know that teaching and caring for students can be a stressful job, so it's important that we provide staff with opportunities to address their own MEB needs to avoid compassion fatigue and burnout.
Very often I hear, and I said it myself when I was a teacher, how difficult it is to bring parents to the table to discuss their child's progress. But remember, we learned earlier that if a child has an MEB issue, there is a high likelihood that the MEB issues may have been inherited from a family member. It can be easy to blame a parent for a student's issues or to place judgment on the parent for how they are raising their child. However, this will not help the student and could very likely exacerbate the issues a child is having at school. There are simple ways a school can provide support for parents through parenting skill development, as well as providing information to help parents take care of themselves. Being a parent is difficult, let alone if the parent is facing their own MEB health issues or issues with their child. It's important to help parents avoid their own compassion fatigue and burnout.
Turning to environmental and community-based process strategies, let's take a look at the remaining 4 areas in our comprehensive prevention framework. Revising school policies and procedures helps create a common set of expectations for student conduct and is necessary to help a school run functionally. But sometimes our policies and procedures can undermine the work we're trying to do to move students forward. Ensure that your policy review committee or the agencies who write your policies are up to date on current MEB research. Revising school policies and procedures can help a school address the environmental CSAP strategy. The next 2 areas on the list are related to data collection, and we know that without data, all we have is an opinion. In all seriousness, though, having quality data can help narrow the focus of any school initiative, but particularly for student MEB outcomes.
Building-level wellness surveys come in many formats, but the overall purpose of these surveys is to analyze the prevalence of MEB issues in a student population, as well as identify the contributing factors to those MEB issues. Typically, these surveys might include questions about how safe a student feels in school, how a student feels about relationships with his teachers, and other school climate measures. These surveys may also address a student's progress with social-emotional learning skills. Other wellness surveys address specific behavioral and mental health topics such as alcohol and drug use, risky behavior choices, and feelings of hopelessness or even suicidal ideation. Some schools may have concerns about collecting information around these topics, but if you remember from the statistics we shared earlier, our students are struggling with MEB health. Many of these surveys keep individual student data anonymous. It's important that we know what issues to address as opposed to trying different strategies that may be aimed at the wrong problem. Schools should choose a building-wide survey that fits its readiness and needs. This data also helps schools to address the community-based process CSAP strategy.
Student mental health screening is a different type of data collection and is key when implementing the CSAP problem identification and referral strategy. This data helps schools and MEB health professionals alike to determine which MEB services might be most appropriate for students and whether a student should be referred to a licensed clinician for a diagnostic evaluation.
The remaining area is community partnerships. Though you've heard many times that a student's MEB health does not exist in a vacuum, we're going to say it one more time. It will be important for a school to develop community partnerships with local providers who can offer MEB supports. Many agencies offer evidence-based prevention curricula or may have funding to support the implementation of prevention initiatives. Additionally, sitting on a community coalition or volunteering in a group who advocates for increasing the protective factors of students in the community can help change MEB outcomes for the students we serve. Community partnerships are an important part of the community-based process CSEP strategy.
If you're like most schools, you have a school improvement plan or a strategic plan. Here's an example of how the 8 key areas we just showed you can fit into your school's planning process. The first step in the process is to conduct a needs assessment. The Ohio Department of Mental Health and Addiction Services has provided a free tool on their website called the K-12 Prevention Self-Assessment Tool. You will receive a link to this tool with your video resource guide. Next, assemble a team who may be able to address MEB wellness supports of students. This may be an existing team, such as a PBIS team, wellness committee, whole child team, or a building leadership team or district leadership team. The key here is to ensure the work does not fall on one person and that the appropriate voices are represented at the table. The K-12 assessment has some questions to help you generate discussion about how to formulate a team and/or evaluate an existing team. Next, analyze the results of your K-12 self-assessment and other potential sources of data, including culture and climate surveys, student MEB health screenings, or social-emotional learning surveys. The K-12 assessment will also give you an idea of sources of data that can be useful in identifying MEB wellness needs of students. From here, you'll begin to develop a sense of strengths and gaps in your services and strategies. Next, you'll need to prioritize the needs you've identified and set measurable goals based on your data.
The next step is to develop a plan to address the needs you found. In developing the plan, use the comprehensive prevention planning checklist with the 8 areas as a guide to ensure your plan is based on evidence. Of these areas, choose the ones you feel can be addressed with the resources you have available. It's okay to start small. In fact, starting small and implementing well will help ensure better outcomes and sustainability in the future. Throughout this process, it will be important to lean on the community partnerships you have available to you to help build your plan and choose the most appropriate strategies and supports for your students. Finally, make sure you set aside time to continue to meet with your team and progress monitor your goals.
To assist you with these next steps, we have provided a planning tool and additional resources you will need to support the implementation of your prevention plan. Additionally, this video is the introductory module in a series. Additional modules are available which delve more deeply into how to implement this prevention planning framework. Contact your local educational service center for more information. For Wingspan Training, I'm Allison Scherer.
For the Montgomery County Educational Services Center and the Montgomery County Alcohol, Drug Addiction, and Mental Health Services Board, I'm Amy Burr. We hope you have enjoyed this training and that you are motivated and ready to build empowered and resilient learners who are challenged and prepared for the future.